Good evening, friends. Welcome to the PG Track program of Delhi CSI, and we are into the 92nd webinar of this wonderful series.
We are live.
It's been a great journey, and from today we are now starting the clinical case discussions, which forms the integral part of all the exams. So we have the privilege of having respected Dr. Sudhay Kumar sir and our dear friend Dr. Kamal Sharma. Along with me on this journey, I have my colleague Professor Girish MP and Professor Sumut Korean. And we also have the privilege of having our dear fellows with us. Look at this, we have Dr. Sunil from JIPMER who will be presenting. Our discussants would also include Dr. Rupesh, Dr. Akhilesh Kumar and Dr. Vikas. And Dr. Shiva, and other people will also be joining soon. Now let me clarify a couple of things. Remember that this is a presentation which is a rehearsal of the approach that you are having towards a case presentation. This is not an examination or any judgment that is going to be passed for you. You are free to commit the mistakes. There is no doubt about it. You are free to absorb all the findings from our learned teachers also. And also, in case you have any clarifications, please feel free to ask. That is very important. Our purpose of these kinds of presentation is not just to give you an idea, but to give you a direction that how to approach a particular case, how to interpret, how to say what to say, when to say, and when not to say, and how to defend your findings. That is the key. You are not judged on your diagnosis, you are judged only on your approach. So I think my learned examiners, respected Dr. Sudhay Kumar and Kamal, would be agreeing with me on this, and my colleagues. So I invite Dr. Sunil. Dr. Sunil, thank you so much for agreeing to present your case. And you can start, you can share your screen, keep your videos on. Dr. Girish will moderate the whole presentation. And Girish, I would request that you can even volunteer to ask other fellows also. In case any other fellows has comments and want to answer a question, you can raise your hand or you can unmute and discuss also. Thank you so much.
Sure.
And please, Dr. Sunil, start your presentation.
So,
I think okay, go ahead.
Good evening, sir. I am presenting a case of a 35-year-old female, housewife by occupation, coming from a lower socio-economic strata, a resident of Delhi, presented to our OPD with chief complaints of dyspnea for last 5 years, angina for last 2 years, and syncope for last 2 months.
Go ahead.
Coming to a history of presenting illness,
Go ahead. I think don't take a break. You continue.
Sir.
Yeah.
Coming to a presenting illness, patient was.
Pause, the examiner speaks. If you continue speaking, examiner keeps quiet. So
Yes,
either
sir.
of the one person is speaking.
Nice
So
to see Dr. Kamal. Now, Dr. Kamal, nice to see you.
Sir, good
Okay.
afternoon.
Good afternoon.
So patient was apparently asymptomatic 5 years back when she developed dyspnea, which was insidious onset and progressive in nature. In the initial 2 to 3 years, patient had dyspnea on exertion, like going to market around 1 kilometer from her home and bringing households, climbing 2 flights of stairs. So NIHA functional class 2, which was gradually progressed over next 2 years to an extent that she was having dyspnea now of marked dyspnea, and she in doing daily routine household activity and climbing even 1 flight of stairs, so equivalent to NIHA functional class 3. These symptoms improves by rest, and this dyspnea is not associated with cough expectoration and any seasonal variation. Patient doesn't give any history suggestive of PND, orthopnea and bendopnea. For the last 2 years, patient also complaining of retroesternal chest pain on exertion, which was in the form of heaviness in the left chest, non-radiating. This pain occurred on climbing 2 flights of stairs or walking at a rapid pace, which gradually progressed to pain on walking 100 meter now and climbing 1 flight of stairs over the last 2 years. So this angina progressed from NIHA functional class 2 to class 3. This relieved by rest, unrelated to any posture or depth of respiration, which also was associated with increase in dyspnea severity. I mean to say that when patient develop, previously my patient was in NIHA functional class 2 for last 3 years, and when she developed angina, her dyspnea severity also increased, and now she is in NIHA functional class 3. In addition to above symptoms, patient also complain of 1 to 2 episodes of transient loss of consciousness for the last 2 months while doing her activity, which remained unconscious for 1 to 2 minutes. This was not preceded by palpitation or skipped beat. This was not associated with any visual or auditory disturbances, any tonic-clonic seizure movement, involuntary urination and defecation, tongue bite, post-ictal confusion, or any residual weakness.
Go ahead.
So are you done?
Okay.
Okay, so
Sir,
positive history, I think you're done.
Yes,
So,
sir.
okay,
Yes, sir.
let's go back to your first page and then that history. Right, so this triad of symptomatology from a resident of Delhi. Delhi, what would be the thing
Sir,
that would come around to your head?
Sir, this triad of symptoms, when we look at this, angina, dyspnea, and syncope.
So my question was to divert you. So examiners can actually divert you to things beyond what you've presented.
Yes,
For
sir.
example, if I am more keen in grilling you on air pollution and cardiovascular outcomes, there is an editorial which is published, I think in Lancet, which talks
Yes.
about CV risk and air pollution. And we know that Delhi has been in news for poor air quality index, especially during winter times. And then she's been a resident of Delhi and who comes with dyspnea, again explainable, angina, again explainable, syncope, sure, for that matter,
Yes.
not explainable.
Yes.
So I can grill you on if I want to divert, and I've been listening to this history say for since morning, and you are presenting this the fourth candidate, and then I might actually start diverting and talk about air pollution and cardiovascular outcomes.
Yes.
So what are the outcomes there? Are you aware of? Have you read that editorial?
No, sir.
How is air pollution associated with CV risk? What are the things that happen more often with air pollution?
Sir, mainly, sir, pulmonary problem, starting from pulmonary problem.
I'm asking you cardiovascular. So pulmonary is, I'm just leaving it. This is DM cardiology exam. So cardiovascular risk of air pollution.
Dr. Sunil, once you get a question, I always tell the students that is the question familiar to me? It's a very unfamiliar question. Second question, are you aware of that area? Have you have a concept about that area? Most likely not. Then it's better say, I'm not sure, sir.
Yes, sir.
Okay, so that you can
Not
save
sure.
time and learn. Otherwise, what happens in the examination is you try to answer and make some major gross errors. The examiners are very happy and they go after that. So the best thing is, if you don't know, rather than saying don't know, I'm not sure, sir. So you will get the next question. You will maybe able to answer. Otherwise, you will get 5 or 6 questions on this topic and you will lose 5 questions. Okay, now you can answer to sir's question.
Sir,
knowing that actually, so it's better that you read up. Okay, no problem.
Yes, sir. Yes, sir.
So triad of dyspnea, angina, syncope.
Yes, sir. So it's indicating towards the valvular heart disease, and this triad is indicating towards the aortic stenosis.
Anything else?
Sir, because sir, aortic stenosis is not alone. Isolated aortic stenosis is not so common, so there may be associated other valvular lesion, and also, sir, this may be also explained by the either LVOT obstruction or RVOT obstruction.
So Sunil, that's great actually. You see, asked to interpret the triad of these symptoms, it's
Yes, sir.
more sensible to talk about the multi-valvular involvement.
Yes, sir.
rather than giving a diagnosis. Okay.
Yes, yes, sir.
That is one thing that you should always be clear. Even if this is the diagnosis, it doesn't matter at all.
Yes,
What
sir.
examiner is trying that whether your mind can interpret and fit all these three symptoms in the respective order in different kind of etiologies, isn't
Yes,
it?
sir. Yes,
So
sir.
that is what you have to say. So your first answer should be that probably, sir, it is signifying a valvular involvement, highly likely of multiple valvular involvement. So examiner will
Yes.
naturally ask, what kind of valves do you think are involved? That second, it could be a cardiomyopathy. You see, you have to play around with the diagnosis rather than giving, so this is aortic stenosis. It looks as if you know the diagnosis, it is wrong. This triad is very classical. So you have to be very clear in your approach. That is what you have to learn. Okay?
Yes.
Please go.
So again, that's the whole point. I mean, one is valvular. So Brunwald's into various sections. So that's what I'm trying to, try to insight from you. It's understood that you're presenting a case of LVOT obstruction. But my point is, are you able to come out with certain other disorders like congenital disorders, like PPH, like
Yes,
Asian
sir.
Bank?
Yes, sir.
Then
Yes, sir.
triad can exist. So can it
Yes.
exist in angle?
Yes, sir. Yes, sir. This
Can
can
it
exist,
exist
sir.
in PPH?
Definitely, sir. This can
Can
exist
it
with
exist in cardiomyopathy?
Yes, sir. HOCM
Can it
most
exist
common.
in constriction?
Sir, syncope we can't explain, but other two, sir, we can explain, sir. Other, sir, Takayasu arteritis.
Can it occur in ischemic heart disease?
Yes, sir. Can occur. The dyspnea
Exactly.
is, sir.
So when we are focusing on symptomatology, the whole point is: are you just pre-focused on to the known diagnosis here, or are you able to analyze it in a different way and look at the whole spectrum of cardiovascular symptoms? That's what we are inclined to ask you. Dyspnea for last 3 years, 5 years, you said. So what I mean, we all know Brunwald's series, right? So
Yes, sir.
5, 3, 2.
Yes, sir.
Right. So does it tell you something here? Dyspnea of
Sir,
5 tell you something
sir.
about LVOT or obstruction,
Yes.
or say, assuming
Yes.
that this is an aortic stenosis, does it tell you something?
Sir, this long history of dyspnea, sir, suggests that there is also associated other valvular stenosis, most probably at LV inflow level, uh, which causing this long history of dyspnea and which was gradually progressive.
Okay, shall I? Okay, fine. I think Dr. Kamal has taken a break. Now, I also fully agree with what others have said. Your approach, the questions will be, what do you think?
Yes.
One, the triad of symptoms, dyspnea first, followed by angina, and followed by syncope. So
Yes.
first, we say primary cardiac problem. And because the patient has dyspnea, which has progressed from class 2 to class 3, it usually indicates pulmonary venous congestion. So for
Yes.
primarily, I will go for a left heart disease. Left
Yes.
heart disease, we have commonest at 35 years female is valvular heart disease. And as you rightly point out, dyspnea is the dominant symptom. It is more likely to be mitral valve disease. Then comes angina and syncope, which indicates LVOT obstruction. So as you have rightly put it, you can say, so the first possibility I will consider will be a valvular heart disease, aortic LVOT obstruction, aortic stenosis, and associated mitral valve disease. Now the question comes, can it be explained by aortic stenosis alone? Because it could be
Sir,
congenital. It could be congenital. Now,
sir,
okay,
Sir, it can be explained. Isolated aortic stenosis, though very rare, very rare, and
no,
looking at the
not very
Brownwald,
rare. No. It's not very rare.
sir,
When you talk
very
about
less common.
rheumatic, you are talking about rheumatic
Rheumatic,
persistent. We are not
rheumatic, sir.
discussing the etiology now. We are putting the physiological diagnosis, anatomical diagnosis with severity, then only we go to the etiology. Now, it could be that the patient has a congenital aortic valve abnormality, which is progressing, and now it has come to a significant level. So don't straight away think. If you say straight away concentrate only for rheumatic, we may get a feeling that you have got a tip that this is a mitral plus aortic valve disease, or a case of multi-valvular heart disease. Because I got the clue because it has been given that is a multi-valvular heart disease. I would not have put it like that. I would have put it like a 35-year-old lady with a heart disease, because then only we can think of different of the problem with you is you got the caption that this is a multi-valvular heart disease. That is the reason we are concentrating only on multi-valvular heart disease or rheumatic ETR. But when it comes to an open mind, first thing, does she have heart disease? Is it something else? So heart disease first, the commonest condition at 35 years with present with this is valvular heart disease. Okay, valvular heart disease with dyspnea as the dominant symptom, it is mitral valve disease with LVOT obstruction producing angina and syncope. Now, does that sequence favors? Do you think the dyspnea occurs before angina in aortic stenosis?
Sir, can be because of the LV diastolic dysfunction, raising
right.
LV in diastolic pressure.
You are absolutely right. You are absolutely right, because we have seen so many cases severe aortic stenosis. Only occasionally we get that exertional syncope. Okay, if it is there, it means it is severe. The prognosis is poor. Similarly, angina also relatively late, whereas they usually present with mild exertional dyspnea. As you have said, it is because of the hypertrophy, diastolic dysfunction. When we put it as angina, syncope, and not, it is not a dyspnea, it is heart failure. There is a sequence: angina, syncope, ASH. Angina, syncope, and heart failure is the last thing which has the worst prognosis. But the earliest symptom is dyspnea, because of the, as you rightly point out, it is the LV diastolic dysfunction. With exercise, obviously the diastolic dysfunction worsens, the heart rate goes up, the LV diastolic pressure, LA rises, so they can have. But if they're going for severe dyspnea from the very beginning, it is less likely. So I will not say that it is totally against aortic stenosis or LVOT obstruction. That is one. Second is valvular disease. Dyspnea, the commonest is mitral valve disease, as you have rightly pointed out, and aortic valve disease. Can it be LVOT obstruction of the cardiomyopathy type, hypertrophic cardiomyopathy? So first is 35-year-old valvular heart disease, of which mitral plus aortic valve disease, fine. Then if it is not valvular disease at 35 years, what are the other possibilities?
Sir, other causes of LVOT obstruction, sir, HOCM, hypertrophic cardiomyopathy.
Yeah. So then you can explain what is the difference in the symptomatology of hypertrophic cardiomyopathy versus fixed LVOT obstruction, valvular obstruction. The same symptom, but what is the difference? Any idea? The symptom threshold varies in dynamic obstruction.
Yes.
The dyspnea may not vary, because the dyspnea is because of hypertrophy, diastolic dysfunction. But the syncope is related to so many other things which could be dynamic. So their symptoms could be dynamic. They will say they can walk this much distance without much problem, but occasionally they can't do this thing. So there is one clue. When you have LVOT obstruction symptom with varying threshold, that is one possibility. So there is, among the cardiomyopathies, you think in several obstructive cardiomyopathy. Fine. Any other possibilities on the left side?
Sir, can we Takayasu arteritis with coarctation of aorta?
Not coarctation.
Only yes.
Not only, because it is a 35-year-old female with the symptom of dyspnea, angina, syncope. Especially in the history, there is associated hypertension or some constitutional symptoms like that. Then I think you have to consider, especially in North India, when I was doing postgraduate, Takayasu was very common. I don't know what is the statistics now. So Takayasu is agreed. What else in the left heart? The next question, can it be ischemic heart disease?
Ischemic heart disease, sir, only this long history of dyspnea and...
No, that's not the way.
At 35 years.
Statistics is the important thing. The 35-year-old AD, without, I hope there are no major risk factors like diabetes, the chance of ischemic heart disease is very low. And that too presenting as dyspnea of long duration. If the dyspnea is of ischemic heart disease of 5 years duration, then she should have severe disease. Very, very unlikely. Even if they're going for ischemic LV dysfunction, they will have short history. So you can say young lady, absence of major risk factors, manifesting a dyspnea as 5 years, and angina is late, and syncope exertion is also not a benign. So it is very low in the list. Then what else? Is it an acute or a chronic disease? Simple, chronic disease. Sir. It's a chronic disease. Is it a progressive disease of physiology, progressive or not?
Sir, progressing, sir. Yes.
So the next thing was, sir asked the question, and you said constrict pericarditis. Can it be? You said the syncope is not. Others are okay. Do you think angina is a feature of constrict pericarditis?
It is not common, sir. Not common.
Not common. It's very, very unlikely. Very unlikely, because If there is angina in constrictive pericarditis, we may think of rare associations or rare mechanism. Similarly, dyspnea as such as the dominant symptom is not common unless you are thinking in a localized constriction. So when you are talking about constrictive pericarditis, what we see usually, they have a dominant systemic venous congestion with associated maximum class 2 at the most class 3 symptom. Angina is very, very difficult to explain. Syncope also explained unless you go for rare association. That is why I look at this case. Deviating from heart, can it be something else? Sir, Dr. Kamal sir has given a clue. Can it be something else? Yes, if it is something else, it is pulmonary. Can it
Pulmonary
be pulmonary?
Yes, sir.
Pulmonary.
RVOT obstruction, sir. Primary pulmonary
Sir is
hypertension.
giving you a clue. It's something that you deal in cardiology. It's in pulmonary bed.
Yeah. So it should be think in terms of pulmonary hypertension due to various causes.
Yes, sir.
It could be chronic thromboembolism, it could be idiopathic, it could be secondary lung disease because dyspnea is manifesting. It could be any of these things. They can develop severe PAH, which can contribute to exertional angina, and they can produce exertional syncope, which is a bad, very poor prognosis. So you have to think of pulmonary hypertensive situations as the next thing. RVOT obstruction is very chance is very low in the list. They can present, but RVOT obstruction isolated, infundibular is rare. Pulmonary stenosis also, their progression is very slow. Their progression is very slow and seldom, even though you can explain that, I don't think I have seen valvular pulmonary stenosis at 35 years presenting with symptoms of 5 years duration and rapidly progressing. Because the rate of progression of aortic pulmonary stenosis is very slow. Either they present with severe pulmonary stenosis in early infancy with symptoms, heart failure, or poor prognosis, or if they present with a mild pulmonary stenosis, the rate of progression is very slow. So once they start developing symptoms, it takes a long time. So you can describe like that. Then you have to say whether there is something else beyond what we have discussed. Okay, Kamal sir.
Yeah. So what is the rate of progression now that sir has told you that it progresses slowly in pulmonary and much faster in aortic? Number one, why so? And number two, what is the rate of progression? Do you have any idea? Why does the pulmonary progress slower compared to the aortic? Either you have, as sir said, either it's neonatal and presenting with very severe PS, so it presents in childhood. But if you find, say, a lady presented, say, 35, and you diagnose her to be having, say, moderate PAS, then probably she'll take much longer. She probably held a couple of deliveries and still she would not have come with a severe pulmonary stenosis. Why? What are the determinants of progression of any stenotic lesion? Sir, what factors drive progression of stenosis?
Sir, afterload.
Afterload or something else?
Vascular resistance beyond the lesion. What is the capacitance and resistance of that vessels beyond the lesion?
That will not drive the progression of the disease. What will drive the progression? Suppose you have a mitral stenosis. When will the mitral stenosis progress rapidly and when will it not? Same way, you have an MR. They say MR begets an MR. But they never say MS begets an MS. Why? Why does an MR beget an MR? But MS does not beget an MS.
Sir, because of MR, sir, LA dilatation occurs, which leading to annular dilatation and further increasing of the MR.
And the annulus
increase.
And the dysynchrony.
Sir. Yes,
sir. So you can have, either it's the gradient or the pathology, right? So what is the gradient usually in a pulmonary? What's the RV pressure being generated and what is the PA pressure? Compare this with the aortic. What is the LV pressure and what is the aortic? Right. So for the same amount of stenosis, the pressure to which the ventricular side of the valve is subjected to, that friction is much lesser on the right side. So if you have a moderate PS, your RV pressures will be like what? PA pressure is 20, RV would be say 60. Compare this with moderate AS, your LV pressures would be 160 with an aortic of 120, right? So you have a gradient of 40 on both the sides, but the pressure to which it is subjected is more on the left side, and hence the progression and it's the turbulence and the friction which is responsible for wear and tear of the valve. That's one. Second is MS. So why does MS progress? There is no gradient, but it is the pathophysiology.
Pathophysiology.
Yes. So that's the rheumatic carditis, regression, fibrosis, mechanism of healing, etc. Right?
Yes.
Again, in dyspnea, angina, syncope, ischemic heart disease. Suppose then, as if you were saying that is not ischemic, then sometimes you can be, again, examiners are usually interested in dragging you to their own subjects, and it can be asked on young CAD. What is a young cat profile? How does it differ in men versus women? Because now, again, what has come up very strongly is genetic biases. I mean, gender biases, women in cardiology, women's health in cardiology, cardiologists as women, women in. So all that has come up very strongly. So you should know gender differences, especially when you're talking about a housewife who's a female patient, right? So how do females differ from a male? So you should then probably also be focusing on gender differences for the disorder. So I think dyspnea, angina, syncope, classical triad, but don't be biased with it. Again, as sir has already said, Sudhay Kumar sir told you that it can be not necessarily be in the same sequence, number one. And number two, it doesn't mean that you cannot have dyspnea for 5 years, even if it's in aortic stenosis. A lot of subjective, because what you have that in series is a median survival in Broadwall series, right? So this is not the cutoff, that this is not the upper limit that you cannot survive with a dyspnea with aortic stenosis for more than 5 years. And then can be some associated disorders like anemia, like infective endocarditis, or say patients presenting with multi-valvular disease that you already mentioned, right?
Yes.
Yeah, go ahead to the next slide.
Okay.
All right. So again, don't say NIHA. NIHA is not the right way to discuss. You should do NYHA. It's a full form. Acronyms cannot be called as, NIHA. What is NIHA? NIHA is nothing. It's NYHA. You should. Nobody calls it NIHA. So don't give them names that don't exist. Either New York Heart. If you want to score more, you should actually call it full New York Heart Association grade class 2. You know. And then when you speak like that, the examiners get prompted to ask you, okay, describe what is New York Heart. Or they are prompted to, okay, tell me Canadian now. Because that's what rhymes, in the examiner's head also. When you say New York, they remember Canada. So they'll ask you, okay, tell me Canadian. So that's how you actually, this is the whole trick of exam. Either the examiner drags you or you drag the examiner, which way you want to answer the viva. So when you describe suggestive of, again, don't say class 2, say suggestive of. Because that's not, patient's history is in patient's own word. So same way when you said dyspnea for 3 months, don't say dyspnea. Patient doesn't know word dyspnea. Patient knows breathlessness. Again, say chest pain, don't say angina. Angina is your interpretation. So ideally, the symptomatology should be ideally described in patient's own word. Don't say syncope, say loss of consciousness. So some of the examiners may be, fussy about you taking the scientific terminology in history, which is not actually the right way. The patient's language is the appropriate way of describing it. When you describe it and call it, say, NYHA2, you should say it that it is in the suggestive of. That's your interpretation rather than patient telling you that I have NYHA class 2. History is in patient's word. All right. Again, you mentioned no history suggestive of. That's fine for PND, orthopnea, and dyspnea, bendopnea. You can be asked mechanisms of each of them, hemodynamics of each of them, hemodynamic correlates of each of them, precipitating mechanisms. What are the other disorders where you can get it? For example, orthopnea. What are the mimics of orthopnea? So people talk of obstructive sleep apnea, bronchial asthma as a mimic, GRD as a mimic. But same way, some new questions can be, what are mimics of endopnea? What are new mimics of endopnea? Which other condition you can have actually no heart failure, but patient has dyspnea on bending?
Commonest?
Sir.
Any person with a pot belly, ascites,
absolutely,
abdominal problems.
Abdominal problems, yes.
Commonest is pot belly. Pot belly they can't. Okay. So it's
Severe
a very
ascites.
non-specific thing. But I have one comment about that. That is, she was having marked dyspnea on doing a daily routine household activity in NYHA class 3. Now, that is a little troublesome because class 3 is less than ordinary activities.
Yes.
Class 2 is symptom on routine daily activities. So, because the NYHA class 2, this Canadian Cardiovascular Society and specific activity scale, all those things will be asked, but this is one thing you should be careful. So that struck me. I may not take you for a drive on this thing because I have so many other things to ask. But the examiners are a heterogeneous group. So next slide. Okay, anything to be discussed in this? Now, the only thing is about that syncope, patient complains of 1 or 2 transients per month while doing her activity.
Yes,
Now,
sir.
was the activity? What is the activity? Okay. How did it get relieved? Did she fall down? It is relieved by taking rest, or she has to, because she had syncope. So that means she falls down.
Yes, sir.
Or on exertion, where she sustained injuries, you have not written that. And how it recovers? It
Sir,
recovers
spontaneous.
on lying down spontaneously within a short time.
Yes,
Okay.
sir. Yes.
Otherwise, it is okay. I think I am very happy with the detailed statement, except telling that he has fallen down and very unlikely. Usually, they prevent a fall unless they are exercising under hot climate. Then they will ask you, what is the mechanism of syncope? I may not asking so many things in aortic stenosis. That's because we have so many questions, or we can have a 1 day discussion on syncope. Various, but the question is here in a cardiovascular disease, especially valvular heart disease, we know that syncope is a symptom of LVOT obstruction than mitral valve, though it can occur in advanced cases when they develop PA. But what is the mechanism of syncope in aortic stenosis?
Sir, while doing activity, it increases the ventricular contractility as well as in diastolic pressure, which stimulate the Bajold-Jerich reflex, mainly mediated by unmyelinated C fiber, and
Okay, so
which
you think
causing,
you think it is a neurocardiac.
yes,
That is the
and decreased
hypercontractile. Okay,
decreased
fine.
cardiac output
Fine,
contributing
fine,
to it.
fine. No, decreased cardiac output not. It's not decreased cardiac output. The cardiac output may not decrease. You are right. There is number one, you have to say you are starting that order rather than going for neurocardiac as the first. You are absolutely right. But first thing is with exercise, the peripheral vasodilation occurs. Number one. So that whatever available blood will go to the exercising muscles.
Yes,
So there will be a reduction in the cerebral blood flow. Why it doesn't happen normally? Normally the cardiac output increases proportionately. Here, failure of the cardiac output to
output.
rise optimally. It need not fall. It is failure. It may not fall. It is failure of the heart cardiac output to increase proportionately to meet the demands of the exercising muscles. So the cardiac output remains relatively fixed. Available output will go to the vasodilator, low resistant, exercising muscular system. So the cerebral blood flow comes down. Third, as you have said, the neurocardiac mechanism, where it is a reflex bradycardia. Fourth is induction of ventricular arrhythmias. One, with the exercise, the left ventricular systolic pressure rises markedly. And that sudden increase in the left ventricle wall tension, the sudden increase in the LV diastolic pressure with subendocardial ischemia, this can trigger arrhythmias, especially in advanced cases because there is another substrate that is the fibrosis. Okay, so these are the things which you have to explain. So you have to look into that also. Sir, Kamal sir.
Yeah, so coming to what sir is saying, continuing with the same, and as my friend Dr. Mohit usually says, if I don't ask some couple of fancy names, my presence is not counted. So what is Bijol-Zurich reflex?
Sir, Bajold-Jerich reflex is uh, increased LVEDP and increased contractility, and causing the stimulation of unmyelinated C fiber,
No, that's not
acting as
Bijol-Zurich. That's
acting
not
as
Bijol-Zurich.
the efferent fiber, and then reflex
So
vasodilatation
basically,
and
when you do
bradycardia.
activity, what is accumulated are vasodilators from the muscle, and they are responsible for the forearm dilatation more than the lower limb dilatation. Especially, this was done by Bijol-Zurich in the physiological labs when they injected veratrum alkaloids into the patient, and they found this response. That's how the name of this name came, Bijol-Zurich reflex by veratrum alkaloids. You have selective dilatation of the territories irrespective of where the activity is done. So patient is walking and still the patient has got dilatation of the upper limbs.
Yes,
When the patient is walking, you should expect dilatation only in the lower limb, but that doesn't
yes,
happen.
sir.
It dilates even in the upper limb. So why does this happen? They found out it's because of the mediators of the metabolites that get accumulated in the lower limb. They will also trigger vasodilatation in the upper limb as well. And hence it's disproportionate to the activity. So even if the patient has walked say 50 meters, he might not have accumulated enough amount of vasodilatory substances from the exercise. But still, there will be dilatation disproportionate to it, because even the upper limb there will be dilatation. And all of this will combinedly give rise to a syncope, which is otherwise not anticipated by the body for the amount of dilatation that you expect only by walking, say, in the lower limb. That is what the whole concept of Bijol-Zurer reflex is. All right, so you can go ahead and now probably move to the murmurs, because we are beyond the half time and we are not finished the history yet.
We can go to the physical finding, because past history may not be that relevant.
Yeah, we can skip this and you can go to exam. Yes.
Okay, fine.
Sir, coming to general examination. Patient is a conscious, cooperative, well oriented with time, place and person. Height 150 centimeter, weight 43 kg and BMI 19.11 kg per meter square. No pallor, icterus, cyanosis, clubbing, lymphadenopathy,
and fine. I think you can go to the next slide, because we have seen that.
Sir, yes sir. Coming to pulse, pulse is 90 per minute, regular in rhythm, normal volume, bilaterally symmetrical, no radio-radial and radio-femoral delay, a delayed peak associated with carotid thrill, all peripheral pulses present and no sign of diastolic runoff.
Diastolic or distal runoff? Okay.
Sorry sir, distal runoff. Okay. Coming to blood pressure, in supine posture, right upper limb 130/72 mmHg and left upper limb 134/74 mmHg, right lower limb 140/80 mmHg and left lower limb 142/80 mmHg.
As sir said, Dr. Kamal sir said, mmHg, why don't you say millimeters of mercury? Why don't you say that? mmHg, you have to put effort. So millimeters of mercury, be a better presentation. Language is also important. Not only your body language, verbal language is also equally important. You'll get a feeling that you prefer short forms and shortcuts. Okay, better usage of, as sir said early, that is N by H. Anyhow, we won't accept it. Okay, go ahead.
Yes, sir. Sir, jugular venous pressure, normal pressure with normal waveform and no hepatojugular reflex, normal hepatojugular reflex.
That's right. And you have to talk about the respiratory variation also.
Again, somebody can, tell you it's not hepatojugular, it's abdominojugular.
Yeah.
Yes, sir.
Reflex. So be precise to the broader terminology.
JVP, you have to say jugular venous pressure is not elevated. Normal waveform, but some examiners will say A and B waves are normal and the descents are normal. That means you are giving an impression these are things I looked into. The hepatojugular reflex, don't say absent. Some teachers say hepatojugular reflex absent. Normal hepatojugular or abdominal jugular, as sir said, is the correct thing. Because you are pressing only the center of the abdomen, periumbilical region. You are not pressing the liver. You are not supposed to press the liver. It will not be compressed. You are squeezing the splenic venous return. Then you should talk about the normal respiratory variation also, normal inspiratory fall. These things important, because JVP try to get away from JVP. Okay.
Sir, coming to inspection, a chest bilaterally symmetrical.
And I think for postgraduates, I usually teach them, they don't say coming to inspection, coming to palpation. You don't, that subtitles are not really needed. It should be just like a novel where there are no subtitles. And I don't know, I will ask the opinion from Kamal sir also. We train to put inspection and palpation combined. That is what we usually train, but doesn't matter. Don't put it on inspection or coming to inspection like that. You can say chest is symmetric. Don't say bilaterally symmetric, chest is symmetric. Okay.
Yes.
Apex beat.
Sir, apical impulse is seen in left inframammary area in the 5th intercostal space at mid-clavicular line, and pulsation seen in the left para-sternal area, 3rd and 4th intercostal space. Pulsation seen in the 2nd left intercostal space.
No can combine it. There are systolic pulsations seen in the 2nd, 3rd and left intercostal space para-sternally. Can make it as a single sentence. Okay.
No pulsation visible in aortic, epigastric and suprasternal region, no dilated veins and scars, and no spine deformity.
Okay.
So coming to palpation, apex beat palpable in 5th intercostal space, 10 cm lateral to mid-sternal line, in mid-clavicular line, LV type and heaving in nature, more than 2.5 cm in area and more than 1 intercostal space.
Okay. Don't give us chance to ask too many questions. Okay. Don't be very lengthy in there. So apex beat is seen and felt in the fifth electrical space confined to mid-clavicular line. Other we may ask questions on this mid-clavicular line, mid-axial line, all those things, and we waste our time. So at postgraduate level, I don't want to waste time on this thing because we have so many other things to discuss. So go for the simple thing. The apex beat is felt in the fifth electrical space in the mid-clavicular line. It is heaving in character. The rest of the things we will ask because if we have enough time, we may ask. We don't have much time. We have to finish it in 1 hour. So heaving in nature, that is all what is needed. Okay. Don't say LV type and heaving in nature. Then the question comes, can you have RV type and heaving in character? Then they will ask you how to know whether it is LV type, RV type or biventricular type. So don't make it complex so that the examiner is happy. So apex beat is felt in the left space in mid-clavicular and it is heaving in character. Okay.
Yes. Sir, diastolic thrill at apex in left lateral position. Grade 3 parasternal heave at left third and fourth intercostal space in phase with apical pulsation.
Don't do this. Sir, there is a grade 3 left parasternal heave. Okay. That means it is in the lower left sternlet. Otherwise, we will ask so many questions. Okay. In phase with apical pulsation, you may be, I don't know, what do you mean? What is in your mind? I don't know. Okay, fine. You may be trained like that, but I may ask, what do you mean by in phase with apical pulsation? Okay, go ahead.
Systolic thrill in the right second intercostal space present, bilateral carotid thrill present, apicocarotid delay present, and palpable P2.
Wait, don't go for unfamiliar presentations. I have not heard, we have not been teaching about apicocarotid delay. Then they will, I may ask some questions I would like to learn also. Epicocarotid delay, what is the normal delay? When will you say it is significant? All those things. Okay. Palpable S2 is better than palpable P2. I am just trying to modify the presentation, not going into the concepts. Palpable S2 in second left space. Then if this subsequent pulsation should go with parasternal heave. So grade 3 left parasternal heave with epigastric or subsequent pulsation. Don't say well sustained RV lift. Don't put like that. Don't jump into conclusions. Okay, then we may ask you what are the differential diagnosis, all those things. Okay, no rub, thrill and palpable. You have said thrill. You have said thrill in the apex as well as in the second space.
Sir, other areas, sir.
Not really needed. Okay.
Yes.
Dr. Kamal, you agree with my comments?
Yes, sir, completely agree. I think writing like more than 2.5, then somebody will ask you, then why did not you measure? Why your more than 2.5 is 10 also? I mean, if you have to mention, you mention it 3 centimeters. I mean, or you don't mention it at all, as sir is saying, you know. So again, when you're doing subxiphoid palpation, sustained RV, I mean, as sir is saying, you either it's palpable or not palpable. So then it's understandable that it's an RV. Otherwise, how would you differentiate mass sitting on aorta? Where would the thumb be hit by a liver pulsation versus RV versus, you know, subxiphoid palpation techniques, etc., etc. So those things you should know, or I mean, unless you are, you know, actually trying to poke the examiner to ask you all that. But again, I could make out that's what you're trying to do, so I'm not going to ask you. I'll take you the other way only. Fine. So I think I completely agree with what sir is saying. You should be more precise, and then don't keep things broad. More than 3, more than half. Be precise. Either it's 4 centimeters, or don't mention it at all. Just skip it.
Yes. My aim is we have only 1 hour. I want to explore or assess the candidate at a postgraduate level. So now already we have taken about half an hour or more than half an hour. But we have so many other things to discuss. So try to be very precise to the point so that you can convey to the examiner that I know much more. That's it. Okay, go ahead. Next. So I will put it like this. So apex beat is felt in the 5th elliptical space in mid-clavicular line. It is heaving in character. There is a diastolic thrill. Then there is a grade 3 left parasternal heave with epigastric pulsation. There are pulsations in the 2nd, 3rd, and 4th space. Then I'll say that the second sound is palpable, and there is a systolic thrill in the right intercostal space as well as in the carotids. That's all what I will put. So at least less than half of what you have discussed. So minimum question from our end also. Next slide.
Percussion upper border of liver dullness is felt in right 5th intercostal space.
Go ahead. This is what I usually do. Go ahead.
Sir,
because, okay. What I am telling is percussion. We are all incompetent. I am incompetent in percussion. Okay, but we percuss after knowing the diagnosis that I want to percuss the right border this much out. But in clinical situation like grossly elevated JVP, I will percuss the right border. Because grossly elevated JVP without right atrial enlargement, chronic suspect constrictive pericarditis. So in a chronic systemic venous congestion, right border is very important. Pulmonary artery pulsation, if it is palpable, you will percuss it out. Okay, so just to quickly complete that, but I may not concentrate too much on that. Auscultation.
First heart sound loud, second heart sound soft A2
You have
with
to tell
loud
first
P2.
sound is loud and sharp or not. So that is also important. When the mitral valve is calcified, the earliest thing to be lost is the sharpness. It may be still louder than normal. So you have to say first sound is loud and sharp. Okay, if it is like that.
Soft A2 with loud P2, hard at apex A2 P2 narrow.
There again you will end up in problem. First is you have talked about the split. Is it normal split? What is the variation with the split? Narrow split is a very questionable thing. Second thing, you can't say P2 is loud and A2 is soft. It's extremely difficult. I will just ask you because you put it. How do you say that the P2 is loud and A2 is soft? Because you can compare only one. Between the two, you can say one is loud. Why did you say that? Why did you say A2 is soft?
Sir, normally A2 should be of.
No, in your case, why did you say A2 is soft? I'm not talking about the theory. Why did you say A2 is soft?
Sir, it is of less intensity than P2 as well as S1 in at base as well as apex.
Why do you say P2 is loud?
Because it is heard in more intensity at aortic area as well as also heard at apex.
We don't concentrate on aortic area. Could you hear P2 in the apex?
Yes, sir.
Why did you say it is P2 and not A2?
Sir, doing dynamic auscultation.
No. Forget about dynamic auscultation. You will be landing. You are giving us more questions. Okay.
Sir.
No, I will tell you.
It is of.
I'll tell you. What's a very difficult area? If you hear A2 and P2 over apex beat, it is a white split second sound with a white loud P2. Suspect ASD. That is a basic thing. If you can hear A2 and P2 over apex beat, it is a white split second sound. Otherwise, it is not possible to hear the split very well over the apex beat. Then, if you are hearing both over the apex beat, A2 is also well heard. P2 can be loud. Over the pulmonary area, you compare. Then how to say is, one is our experience also. But if in the pulmonary area, P2 is louder than A2, I may take it as P2 is loud. Because this is a situation, what you are expecting, definitely loud P2. Because there are other features of PH. So forget about A2 because you are anticipating because you wanted to diagnose aortic stenosis. Then narrow split also, they will ask the definition. Because in standard phonographic definition, there is normal, single, paradoxical. Okay.
Yes.
There is nothing like close split by definition also, but some seniors may say it appears to be close split. If you are hearing the split, have you heard the split?
Yes, sir.
Then you say it is normal split. Okay. Now you are anticipating some abnormality, that is the problem. You are anticipating, what do you anticipate in the second sound in the case with the diagnosis which you have? What do you expect?
Sir, loud P2 with pulmonary feature suggestive of
split.
Split, sir.
There is aortic stenosis, there is pulmonary hemorrhage.
Yes, sir.
What do you expect?
Expecting, sir, A2 P2 gap becoming narrower, then a single and ultimately paradoxical.
I will think that you have anticipated this thing. That is the reason why you have put narrow split. Okay, but to me, if you are hearing the split in the pulmonary area, then is it served only in inspiration or expiration or both? That is the next step. It is not an easy business, but you can put you in trouble by bringing some confusion there. So what you have to say is, so a second sound, it is normally split, it moves normally with respiration, then only you can make the narrow split, and sir, the P2 is loud. Don't comment about A2 at that point. Extremely difficult. Okay.
Yes.
I am helping you to get away from the examiners.
Yes, sir. Sir, loud opening snap, best heard medial to apex with narrow A2OS gap. No S3, S4 click or rub. Then the low pitch, rough and rumbling mid diastolic murmur of long duration extended till the end of diastole, associated with perisystolic accentuation, best heard at apex in the left lateral position with breath held in expiration with the bell of stethoscope. And this murmur increase in intensity with isometric hand grip and decrease with standing and inspiration.
Okay. Now, basically, I agree with you, but I try to get away from JVP, dynamic auscultation, Bell-Salva manual, second set. Minimum scope for facing questions. For mitral stenosis, when it is so obvious, there is no need to do dynamic auscultation. In a suspected mitral stenosis, you may do dynamic exercise to increase the heart rate, increase the venous return. But here it is so obvious. Dynamic auscultation, usually we go mainly for faint murmurs, regurgitation murmurs like that. For a florid mitral stenosis like this, where you have heard an opening snap which is very close, long murmur, I think for mitral stenosis, dynamic auscultation need not be mentioned. Okay.
Okay.
Regarding that slide page, I think Dr. Kamal, regarding this page, I made some comments.
Yeah, I think it'll be very interesting to come to your diagnosis, because now what has happened that you have committed your symptoms more in favor of aortic stenosis, the way I felt. Your auscultation is favoring more of mitral stenosis. Your A2P2 you would expect to be paradoxical. So when you have to come to your diagnosis, it will be very important what you are weighing. First, symptoms. Second heart sound. Third, apex. Fourth, PAH.
Yes,
okay.
Sir. Yes, sir.
And the pulse character, the JVP, and the blood pressure. Now, your blood pressure was actually slightly wide.
Yes, sir.
Right? It was not narrow. Sir, yes. Yeah. And you had syncope and patient is in sinus rhythm. Now, usually the proximal lesion will mask the distal symptoms, right?
Yes,
if you had a severe mitral stenosis, I would probably be surprised to find a patient presenting with a moderate AS with syncope. If the patient is presented with syncope and patient is in sinus rhythm, which is probably that he did not have an AF and it was related to AS, then AS has to be severe enough, in which case the findings would go for AS, because otherwise this patient, if he had a aortic stenosis and syncope and you had a severe mitral stenosis, syncope is less likely because the symptoms of aortic valve will be masked by mitral stenosis.
Yes.
Okay. So go to your next slide. Next slide.
Okay,
next
just
slide,
a minute.
Next.
Just one sec. Shall I? Now, with the findings unbiased, you should find out which are the possibilities and what are the things which you have to look for.
Yes.
Okay. We have thought about mitral valve disease plus aortic stenosis. Here, slow upstroke which has been confirmed, but the blood pressure is the oddity.
Yes.
When you have severe mitral stenosis with pulmonary hypertension and aortic stenosis which has produced a healing effect in presence of mitral stenosis and a delayed pulse, your diagnosis is severe aortic stenosis, severe mitral stenosis. How will you explain the blood pressure? That is the next thing. So, what will you look for?
Sir, associated regurgitant lesion.
That's why we have to carefully auscultate for aortic regurgitation. So that should be the auscultation. So go ahead with the second page of auscultation. Next.
Other auscultation.
Next. Yeah.
Sir, harsh ejection systolic murmur of grade 4/6 long duration with late peaking. Peaking in second half of the systole, crescendo decrescendo configuration. Radiating to both carotid, best heard with the diaphragm of stethoscope in second right intercostal space, sitting and leaning forward position. And this murmur during expiration, this murmur decreases with standing and inspiration and hand grips.
I always tell that the sitting leaning forward is only for aortic regurgitation, not for a grade 4 murmur. There is a faint murmur of aortic regurgitation, we may have to do all those things. Not for aortic stenosis. I have heard quite often the students presenting like this. At MBBS level, I may teach them, but not at postgraduate level. Okay, so you should not use that. It should be precise postgraduate presentation, grade 4/6, long murmur with late peaking. That's enough. Decrescendo, decrescendo. Fine, go ahead.
Yes, sir. Sir, then a high pitch blowing grade 3/4, early diastolic decrescendo murmur extending up to less than 50% of diastole, best heard in the third intercostal space with diaphragm of stethoscope in sitting and leaning forward position in held expiration, and this murmur increase with hand grip and squatting. AR murmur I am expecting.
So there again the problem is in dynamic auscultation you did so many things. Okay. So
Yes,
all those things are not needed. For example, for EDM you have used one thing, squatting. The other you have used standing, inspiration, hand grip. It's not needed. When
yes.
it is so solid, it may not be needed. In doubtful cases, you can do that. Or you can say it increases in what commonly we do is standing, supine, all those things. When it is like this, you need not go for squatting, all those things. Okay. There's no problem. At MBBS level, I may go for this thing. At postgraduate level, I may not. Because this should be applied in a given background where you want this to identify. For example, you have an LVOT obstruction or a mitral regurgitation or a doubtful finding. You may have to go ahead.
High pitch blowing grade 3/6 pansystolic murmur best heard with the diaphragm of stethoscope in 4th and 5th intercostal space at lower left sternal border while doing inspiration, squatting or leg raising. So this
there again a problem comes. You are telling that this grade 3 murmur is appearing only during inspiration. No,
yes,
sir. Very unlikely.
Because sir,
a grade 3 murmur appearing on this thing will be audible in the usual line, but that is my experience. A grade 1 or a faint murmur you may have to elicit by this thing. Okay, fine, go ahead.
What's the name of these gradings of murmur?
Sir, Levine grading, sir.
Levine's grade. So
yes,
why are the diastolic not graded up to 6?
Sir, diastolic one. If you think about the MR, then it is the LA is not so strong to contract. One is the mass, sir. While in the systolic murmur there is large mass contracting, so it will produce the more. And the second is it is the passive mostly, as in AR, it's coming passively.
I am the co-examiner. I am not familiar with the answer for that, but the question was why there is a difference of grading for grade 6 and grade 4 for diastolic. What is why it is? Let me finish. We have to say that the original Levine graded this only for systolic murmurs. Then there was a confusion regarding diastolic murmurs whether it should be graded or not. Then the grading came, and finally there was a consensus that is grade 4 by grade 3 by 4. I also don't know the answer for that. Dr. Kamal, you have the answer for that?
Sir, LB mass contracting against for systolic, so that's why.
What is grade 5 and 6? What is grade 5 and 6?
Sir, grade 5 is the murmur which can be heard even after the part of.
Say that no, that can murmurs of diastolic nature be radiating and be heard away from the side? It can't be. So either you have 4 and then the rest is 5 and 6 don't exist for diastolic murmurs. And what you are giving is the pathophysiological mechanism why it can't be 5 and 6. My question is because diastolic murmurs are primarily localized murmurs. They are not transmissible radiating murmurs. That's why you don't have 5 and 6. 5, 6 is like stetho lifted up and you are hearing. That can't happen, right? So that's the reason that you grade diastolics up to 4.
You can ask a question to me. I disagree with you, sir.
Yes.
Can you disagree with me? Okay. Mitral stenosis murmur.
Yes, sir.
Mitral stenosis murmur can be easily palpable. It can be grade 4. It can be still louder. You can ask doubts also, sir.
Yes.
But occasionally can it happen? Okay, that is the way a postgraduate should behave. No, we will accept it, sir. But sir, we have heard occasionally diastolic murmur to be very loud, especially in thin people, all those things. But that is the answer for that. Okay. Yes. A good student can be diplomatically or politely ask some questions also to the exam, so we can learn more. Okay, fine. Yes. But that is the answer because seldom it is more than 4. And it is usually localized. Fine. Next.
Sir, no abnormality in respiratory system. So coming to a diagnosis. Chronic valvular heart disease of rheumatic etiology, significant AR, moderate AR, I am thinking, and mild TR with moderate moderate pulmonary venous hypertension and moderate to severe pulmonary arterial hypertension in Newark Heart Association functional class 3 in sinus rhythm without thromboembolic complication, no feature of congestive cardiac failure, infective endocarditis and active rheumatic activity.
So how would you determine the dominant lesion in these two? What do you think is I am not differing in any way. That's that it's not both severe. One of those will be, of course, you can have both severe. But how do you then determine the dominant lesion? Which of the two is driving the pathophysiology and the hemodynamics in this patient? Which of the two, mitral stenosis or aortic stenosis, is driving the hemodynamics? So I already gave you a clue as to what are the parameters that you look at.
Yes,
and based on that, which you think is the dominant? Is it MS or AS?
Sir, looking at the duration of the symptoms, long duration of dyspnea, and then blood pressure is of course not supporting
long
mitral
nature would not
stenosis.
matter. In the current situation, whichever is the dominant will determine your hemodynamics. So hemodynamics are determined and reflected by JVP, blood pressure, pulse, apex beat, pulmonary hypertension.
Yes.
Right. So all of them is favoring what to be dominant here?
Sir, feature of pulmonary venous hypertension along with severe pulmonary hypertension like grade 3 para-external heave, these are favoring sir severe mitral stenosis, and other features like apex, blood pressure, and angina syncope, these are favoring sir severe stenosis along with regurgitant lesion.
So do you have is the ECG or X-ray with you?
Just I would like to contribute to that question, because really difficult question. How we will tackle? I have one or two questions related to that. One, mitral stenosis, as you have said, is the dominant. And mitral stenosis is severe, PAH is severe. I may ask, why do you say it is severe PAH? To say severe PAH, you should have an ejection click, pulmonary vegetation murmur, or a prominent day wave, or a right ventricular fourth sound. Parasternal heave is modified by so many things. So you can say severe PAH or moderate to severe PAH, agree. Okay, pulmonary venous hypertension, we need not say moderate. Why do you say moderate? What do you mean by moderate pulmonary venous hypertension? We don't classify that. Okay, okay, fine. It's a pulmonary venous hypertension. Now, chronic multi-valvular heart disease, you can use that. Multi-valvular heart disease, rheumatic etiology. Now, the point I would like to ask is, when there is severe mitral stenosis in the aortic stenosis, as sir said earlier, that mitral stenosis proximal lesion influences the distal lesion, so that the aortic stenosis problems can be exaggerated because the preload is less, stroke volume will be less. Now, what are the factors which influence degree of aortic stenosis in this case? What are the factors which mitral stenosis not significantly modified?
Yes, sir. Regurgitation is.
No, my question is very clear. What are the factors which influence the severity of assessment severity of aortic stenosis? That is a question which I want to ask.
Sir,
yes.
One is symptoms.
Underestimate or overestimate the severity of aortic stenosis.
Yes, sir.
What are those factors which are modifying the severity of clinical judgment of aortic stenosis?
One is severe mitral valve stenosis. Severe mitral stenosis, less filling.
Fine. That we have said. Pulmonary hypertension, severe mitral stenosis. That produces dash aortic stenosis.
Sir, less severity. This will produce.
There's a terminology for that. That's what I want. There is severe mitral stenosis and severe pulmonary hypertension, and or severe pulmonary hypertension can produce hemodynamically.
Sir, paradoxical, low flow, low gradient, severe aortic stenosis like features, sir.
You come with that, you will get bonus marks.
Yes, sir.
Okay, so you have to put it like that. Sir clearly said the proximal lesion influences. So there are two proximal hemodynamic mitral stenosis, PAH. Sir, it can contribute to paradoxical, low flow, low gradient aortic stenosis. I will give you bonus marks. I may not ask much questions. Now, what is the other thing? High gradient, high flow aortic stenosis. It may not be severe. Is there any factor which is contributing to that?
Sir, hypertension, sir, can contribute.
No, it will not produce high gradient. Aortic regurgitation.
Yes, sir.
When there is aortic regurgitation, the flow increases.
Yes.
And the gradient also increases. So if you bring in that two terminologies in this case, I will be extremely happy to give you distinction. Okay, fine. Go ahead.
So,
electrocardiograph.
Sir, Rupesh will be projecting.
Yeah. So
but the patient, can we have the ECG or X-ray? Which of the two you think is going to help you to determine the dominant lesion between the two? Aortic versus mitral, which will be more helpful? What do you think?
Make me
Rupesh?
the host.
Sir,
Yeah,
Rupesh.
Sir, make me the host, sir.
I will
ECG.
put
yeah,
that-
you,
I will
yeah,
put that
you
question.
don't.
Shall I put that question to the 4 participants also? Let them write down. Let them write down.
Yeah,
Okay, sir.
I
yeah,
think
all of them.
that will
Anyone
be
can
right, sir.
unmute and speak.
Yeah, because he has been grilled for quite some time. Others might have been enjoying the show.
Sir, please pardon the question.
Sunil,
Yes, sir.
you stop sharing and let Rupesh start sharing his screen for
Do
ECG.
you want,
Rupesh, sir.
Rupesh, do you want X-ray or ECG and how it helps? A common question. I will say both are useful. Now the question is, which would you like to have? There is
Which
Rupesh.
of the two will be more helpful in determining which of the two lesion is dominant? That's the
Sir,
question.
Sir, X-ray, sir, I would love.
Okay. I also prefer
X-ray, sir.
Why?
X-ray, I will prefer, sir.
Why?
Because, sir, if aortic stenosis with not severe AR LV, which will be of normal,
No.
and
We are trying to.
so look into.
We are trying to see whether mitral stenosis is more dominant or aortic stenosis.
Sign of LA enlargement with main pulmonary artery dilatation, RPA dilatation,
Yeah,
will give the clue for severe mitral stenosis, sir. And for severe aortic stenosis, we can't give much full clue from X-ray because
So
if
LV
LV
versus RV forces, whether the
Yes, sir.
RV forces are more or LV forces are more, is more likely to be interpreted by X-ray or ECG.
yes, sir, X-ray, sir.
Forces are
Forces by ECG, sir.
Sir,
Forces by
Absolutely,
ECG.
you will look at
ECG.
the axis, you look at the PAH,
ECG,
and look
sir.
at the
Yes, sir.
LA. All
Yes, sir.
can be picked up on ECG.
ECG, yes,
So
sir.
when we both know that both of them are there, when you want to determine which of the two is the driving hemodynamics, you will look at the chronicity by the axis. You
Yes.
look for the chambers again by all of them. The pH you can also be picked up, and again volume overloads by the tall T.
Yes.
Right? That will not be picked up on X-ray.
so.
Okay.
What you have got is both will contribute. But if
Of
you
course,
are
both
asked,
will contribute.
if you are asked, you have to explain why
So
you are choosing
can somebody
this.
read this?
Yes.
Can read the ECG. Can Rupesh, are you reading this ECG or you want somebody else to do it?
Sir, I'm presenting it, sir.
Yeah, read the
Not
ECG.
Rupesh.
Rupesh is presenting. So who amongst the residents, anybody says, the Sudhay Kumar sir has said, anybody can actually.
I think Vikas, I think he's
Yes,
quite
please.
active on chat.
Good
You
evening,
can
sir.
try, Vikas.
Who is discussing now?
Dr. Vikas Kumar, sir.
Okay, fine. Go ahead. Let us see
Can
you
you-
also video. Okay. Fine. Go ahead. Quick. Yeah.
Sir, this is 6-channel 12-lead ECG.
I won't because we are running short of time. What I usually ask is because I expect a postgraduate to read the ECG systematically.
Yes, sir.
We have been discussing how this ECG helps in your evaluation of the two lesions. You tell me these are the points which are favoring this, these are the points which are favoring this. So from the ECG, I think it is more likely to be aortic stenosis dominant or mitral stenosis dominant. That is what we want.
Yes, sir. Looks like it is aortic stenosis is dominant, sir.
Why? Yeah.
Because I see normal axis and LV forces are predominant, sir. I can see LVH by voltage criteria, sir.
Okay. You can tell points in favor as well as points
And
against.
RV forces are not predominant,
Okay.
sir. Like I don't see a deep S in lateral leads. And
Okay, so you
RV
think
not
it is,
dominant.
it's a simple thing is, sir, this ECG is LV dominant.
Yes, sir.
Okay. Now, does it show features of severe aortic stenosis?
Sir, actually, LVH with the strain pattern is not
No,
seen.
the question is very clear. That's
Yes.
what we have to do as a postgraduate. Do you think it is favoring severe aortic stenosis?
Not really, sir. Actually,
No, because there are no ST changes. These are
Yes.
the limitations. What do you think about mitral stenosis?
mitral stenosis, sir. I
What are
was
the points in favor or against? Severe
against
mitral
is the axis is not right axis.
But more important is left it.
And RVH
What is the axis, Vikas? If you look at the axis, lead 1 is 0 almost.
Yes, sir.
And AVF is positive. It's 90 degree. What do
Yes.
you expect in aortic stenosis? It should go leftward.
Leftwards, sir.
Your axis is actually more towards right. right? So that's the one finding which is actually going in favor of mitral forces,
And
right?
you have pulmonary hypertension also.
Yes.
Most
Then-
prominent
And you don't have R wave in V1, but you have, look at the P waves in V1.
Yeah.
Yes,
What
sir.
is it?
Sir,
P-
Morris
P
index,
mitral or P pulmonale?
P pulmonale with
Pulmonale.
Morris index.
No.
P
It's not
mitral.
Biatrial, right? So when you're looking at biatrial, you're probably looking at, again, mitral forces coming in, right?
Sir.
Okay,
PH.
I am a
RVH
little,
is not there. RVH is not there, but axis is 90 degree. You have biatrial enlargement. Morris is there. I think the fourth QRS complex is biphasic in the lead V1. But if you look at the other ways, the P in lead 2 also, the P waves are not so tall. So at least the LA enlargement is significant, which can happen in both MS as well as AS. So that doesn't help you. PH is not so much there, but the axis is 90 degree. And as we all know, that if your axis in a patient of mitral stenosis is more than 60 degrees, you're dealing with a valve area suspected less than 1.3,
1.3.
right? And if your axis goes beyond 110, you're dealing with a severe PH situation. But because this patient has got aortic valve disease, so the axis would also tilt slightly to the left. So despite AS, if you're getting an axis of 90, those are the hidden signs of a severe mitral stenosis.
so the way I read this ECG will be, sir, sinusoidum with QRS complexes, voltage weight suggests LV dominance. Regarding the axis, it is more than plus 60, maybe near 90 or plus 75. I expect an axis 0 or towards the left if there is pure severe AS. So there are biventricular forces. That will be my conclusion. Regarding R in V1, it is not seen, but I would look for a V3R also to see whether there is a taller RV. Regarding the P wave, I have some reservation. I may not be happy with the Morris index. It doesn't show the typical. I expected a much larger negative deflection. So the P wave, I thought in V1, the P wave is 1.5, and in lead 2, it doesn't show the typical broad P wave with a short PR segment. I am not sure. That's an area where I say I'm not very sure about that. Once you talk about Morris index, you may be asked about macros index, all those things. Fine. I will say that this electrocardiogram will show voltage-wise, LV dominance, axis-wise, there is a towards RV, axis is towards the right. So I may go for a biventricular involvement. Regarding the atrial pattern, I'm not sure. That's what I said. That I will look into the X-ray. That's the way I proceed. Because we can keep an open mind and discuss that. I will go to the X-ray to see what is the left atrium. Yes.
Sir, can we say here electrical alternance?
Pardon? Electrical alternance.
Where do you find that? Which place?
No.
Sir, here. Sir,
No. There is not alternance.
No. This is not. What is
the
ECG definition of electrical alternance?
Sir, alternate.
Yeah.
Difference of how much? This much you can get even in respiratory variation.
Yeah, this is respiratory variation. It's a gradual increase, and this is a respiratory variation.
So the difference should be 25%. The tallest star and the shortest star, 25% if you have amplitude change, then only you call it electrical. This is not 25% if you compare the tallest with the shortest. Now go to the X-ray, please.
You should be careful. Just a minute, you should be careful when you bring in electrical alternance. When it should be clear, then we are not anticipating electrical alternance in this case. And you will be asked questions on electrical alternance, the mechanical alternance, all those things. Okay. Next X-ray.
Sir, will the presence of U wave favor some valvular heart disease? Out of the two?
Favor valvular heart disease. U wave is whether it is abnormal U wave or not. There is no abnormal U wave. There is nothing impressive. And the U wave doesn't favor valvular. Prominent U wave, you have to look for so many causes. LVH is a common cause for prominent U wave on the left side. It is not prominent. Then you will be asked questions on U wave. Then will you say it is prominent? All those things. X-ray chest.
X-ray, please. Yeah. Okay, read this, please.
Okay, my question is, after the X-ray is suggestive of?
Sir, X-ray, I am reading, sir. Chest X-ray.
Reading, sir. Because we know. I'll just
X-ray, suggestive.
Suppose X-ray is given, what will you diagnose?
Sir, this is suggestive of left atrial enlargement.
What is the diagnosis? What is the diagnosis?
Sir, a severe mitral stenosis.
Okay. Why do you favor severe mitral stenosis?
Because sir, looking at right heart border, there is
No, it's
double
not
contour.
Not that.
Main pulmonary artery.
Postgraduate line of answering is, sir, there is moderate left atrial enlargement. If it
Yes,
has been
grade
above,
2.
it should be
Grade.
severe. There is a moderate left atrial enlargement with evidence of pulmonary venous and pulmonary arterial
hypertension. Yes,
without significant cardiomegaly.
sir.
Okay, but what is the oddity? Some examiners are interested in the apex. What is the apex like? I never asked
Sir,
that.
LV type of
It is
apex,
dipping down. So
Yes,
I
sir.
expected an RV apex, but the apex seems to be LV type. So
Yes.
that may indicate LV apex occurs dips when there is
associated AR also, sir.
significant LV dilatation.
Dilatation.
It dips down because the apex ventricle enlarges posteriorly. So transverse enlargements may not be there. You may find significant left ventricular enlargement without significant CT ratio increasing. But because it can enlarge posteriorly, radiologically you have to take the lateral view to look for LV enlargement.
What is that sign? Anybody can answer that? What's
Hoffman regular sign, sir.
Correct. So what are the newer signs on that? Some more named signs? Apart from Hoffman regular, there is one more sign. And what is the measurement of it?
Sir, from IBC to we take from IBC to how much it is extending backwardly. If it is more than 15 mm, then it is called
what are its
positive.
fallacies? Is it now the gold standard? Actually, the newer Brunwald doesn't mention Hoffman regular. The older generations that we read always had it, So now the newer generations, because it's not a very specific sign.
Yes.
Yeah, it has a good sensitivity, but not a very good specificity, and hence it is not there anymore in radiology. There are some more signs which have been looked into the lateral chest X-ray, which again you can search and then go through them. Again, as sir is mentioning, what do you think about the pH here? Mild, moderate, severe?
Sir, pH, sir, curly B line is also there. So, sir,
no, so
at
pH,
least
curly lines don't go with PAH, they go with PVH. Don't make those mistakes. So pulmonary venous hypertension is reflected in Curly's lines. Curly's lines are not finding of arterial hypertension.
So
arterial
at least
hypertension is reflected by pruning. So you have peripheral pruning and central PA dilatation. If you have a central PA dilated along with DRPDA, descending right pulmonary artery, more than what cutoff?
Descending
DRPDA
more than 15.
And central PA more than 25, then you're dealing with a case of
severe pulmonary.
So that's grade 3. So arterial hypertension, as Professor Sudhay Kumar sir said, if you have central PA, severe PH, and that's what is telling you that this is the mitral forces that have come into play. Right. The plan of management.
So finally, what you have to say is this patient has severe mitral stenosis as evidenced by the symptoms, the clinical finding of an early opening snap with long murmur in presence of aortic valve disease. Because when presence of aortic valve disease, the A2A syndrome gets longer. And evidence of severe PH clinically and radiologically, it is severe mitral stenosis. Aortic valve disease is also significant because despite severe mitral stenosis, ECG is showing left ventricular forces. So you have to say,
yes,
I think that is a way.
I agree, sir.
That is the way you have to put it. So rheumatic multi-valvular disease, rheumatic heart disease, mitral stenosis severe, aortic valve disease, aortic stenosis severe, aortic regurgitation moderate, pulmonary arterial hypertension, tricuspid regurgitation, like that. Okay, fine.
What do you do for this patient? What would you offer him?
Sir, patient is already symptomatic, so a double valve replacement along with medical management first, along with double valve replacement.
So don't jump to the valves because some of the examiners can grill you. Won't you look at for acute rheumatic carditis? Won't you look at infective? Won't you stabilize him? Won't you give diuretics? Won't you start penicillin prophylaxis? What about rhythm? Won't you look at a TE? So just say apart from routine investigations, which include workup for the carditis and stabilizing him medically and putting on adequate rheumatic and infective endocarditis prophylaxis, then you would be subjecting. So when you say usually a DVR, which is the commonly offered answer, the question can be, this is a loud S1, won't you offer AVR plus OMC?
Yeah, that's it.
Yes,
I think
sir.
you should not jump to that thing. You should have said that the question is, what will you do? So you do the baseline investigation. I do a detailed echocardiographic evaluation to assist, confirm your diagnosis. Second, don't straight away go for DVR. If the valve is pliable, you can go for aortic valve replacement with open mitral valvotomy. Or if the aortic valve stenosis is not that severe as you expected, I would like to have an echocardiogram, because if the aortic valve disease is not that severe, somebody may say that we will do a balloon mitral valvotomy for the time being and then follow him up like that, because this can be seen in two separate angles, aortic valve disease separately, and this can confirm that both are severe. So I would just like to have a glimpse at the echocardiogram. If you have some data, that's all we want. I don't want the details. Okay, simply looking at that, aortic valve was opening fairly well. Okay, it is doming, it is opening. Okay, fine. Okay, fine. Fine.
Okay, next. Yeah.
Yeah.
So why would you argue for, say, AVR plus OMC and then not actually go for DVR? Somebody would be prompted, no, you're opening up the chest. Why would do a later? Put the two valves in. Why is AVR OMC a better strategy rather than?
Because sir, we are damaging the papillary muscles in mitral valve replacement.
Okay, your surgeon is very expert and he says, I'll do total caudal preservation. I'll put a valve in valve, nothing chopping, nothing doing. Still, I as a cardiologist, I would say, no. I am going to get only an OMC. Why?
Sir,
even if he's preserving the chordae, papillary muscles, everything.
Sir, one is,
what is the requirement of anticoagulation? Number one, what is perioperative mortality?
Mortality, yes sir. Mortality is around 9%, sir, in MBR plus DVR. Matlab MBR plus AVR. Second is anticoagulant requirement and chances of stuckness of valve, two valve is there. So
I'll put it like this. I always prefer to have the native valve in situ. That is the number one thing. So if you can open the valve, it will have a good long term.
Absolutely.
And that is the number one thing. Second, as we have said, the operative mortality for a simple aortic valve, which will be in a young patient 2 to 4%, will be jump to 7 to 9% when there is double valve replacement. Then the stiffness for anticoagulation. When there is mitral also, it goes much higher. So I will definitely prefer looking at that valve. I will meticulously look into that, and I will prefer aortic valve also. I will look into that whether aortic valve the gradient is high, but in the cross-sectional valve area 2D it seems to be fairly good. Forget about that. That the consultant will decide. I think we had enough. We have exceeded time. Am I right, Dr. Kamal? Have we exceeded the time?
Yes, sir, we are beyond the time.
Yeah.
So I think we can, Dr. Mohit?
Yeah, perfect.
Yeah, okay. I think this thing is, the candidate has presented reasonably well. The history has taken really completely. He has to modify a little bit the presentation at a postgraduate level. We have presented complete, perfect presentation, but at a postgraduate level, you have to modify it in a better format. Findings are great. At second sound, you should be careful. Certain things in your presentation, you can modify, you can brief it a little more. We have been answering fairly well, and we are happy with your presentation. And other person who has participated in the discussion also has done well. I really enjoyed the show because Dr. Kamal has been enjoying, I have been enjoying, and the student has been benefited, and we are happy with your presentation. And thanks, Dr. Mohit, for calling me again and again to share the platform with people, especially with Dr. Kamal. Learning a lot.
My pleasure always.
Learning a lot. Many things.
Not at all, sir. Not at all.
Many things that science, all those things. Because Brownwald has changed his concept because the students have to learn a lot new things. So clinically, they should know important things. I think it has been a wonderful discussion regarding ECG X-ray, the way Dr. Kamal has discussed how the ECG, how the X-ray, and the proximal lesion versus the distal lesion. To answer which is severe mitral stenosis or severe aortic stenosis, which is more dominant, it may be difficult, but diplomatically you have to say, sir, mitral stenosis is severe because he has symptoms, he has PA, there is a long murmur, short A2I syndrome. What about aortic stenosis? Sir, it is also symptom because the patient has symptoms, he has a slow rising pulse, he has a heaving effect. So we have to be very diplomatic. But more important, if a question is asked, see whether the question is familiar or not. If familiar, you have to answer. If the question is not familiar, are you solid in that area? You can deduct the answer, intelligence. You will get more marks. Unfamiliar questions, you should be careful. Question unfamiliar, Area unfamiliar, don't open your mouth. It will be a blunder.
Yeah, thank you very much, sir. Again, as I completely endorse what sir is saying, I also enjoy with sir. Sir is very systematic. Actually, I see him writing down the points with the examiner, like the old examiners used to do. When the candidate is presenting, he jots down it on a pen and paper and then analyzes it critically and helps you all to interpret and come with the conclusion. So always a pleasure being with you, sir, Dr. Sudhay Kumar, sir, and always a pleasure being with CSI Delhi, especially my friend Dr. Mohit. Thank you for inviting me every time. It's always a pleasure. And I enjoy the platform, and I think all the candidates did very well. And sir has summarized, there's not more much that I can add. But I always insist that you must read the new edition of Brunwald, which has come now. The international edition is already now there. The Indian edition may come soon, but I believe the content is going to be pretty much the same. And again, they've come up with a lot of new chapters. There are chapters on amyloid art as a separate. There's a new chapter on sarcoid, which is separate. There is on the clinical examination, they have come up with certain odds ratio, likelihood ratio for various statistical analysis for the various clinical science, which is how the science of clinical examination is also evolving. So I recommend that all the students who are going to appear for the exam go through the new edition of Brunwald's textbook of cardiology, where the clinical chapters are also being modified to some extent, especially with the newer studies. That's from my end. Thank you very much for having me.
Thank you so much, Sudhay sir. Thank you so much, Kamal. Thank you so much, Sunil, for presenting.
Thank you, sir. Thank you, sir.
It always gives you more confidence and a great learning experience. It's always a learning for actually all of us. I also thank my colleague, Dr. Sumod and Dr. Girish, and all the fellows, Shiva.
We could not see Sumod, Girish.
We'll be having more case discussions next time, and hope you all prepare and actively participate in a more proactive way. This particular session will be loaded on the YouTube channel. You can download and re-listen it. I thank you, Intas, for providing us this platform. Next week we'll catch up with another wonderful session. Thank you. Have a safe week. Enjoy and good night.
Thank you. Bye-bye.
Mr. Sumod and Girish. Okay.
Thank you, sir. No, sir. I'm very much present.
Thank you, Dr. Girish, Dr. Sumod.
Sumod. Okay, fine.
Okay, sir. Okay, sir. Thank you so much.
Thank you, sir.